Hello. So I'm going to try to bring some of my experience, because I think that's what these symposiums offers. We bring experience from other areas and other patients that we treat, as well as people that have APS-1, and what can we learn from each other to actually make everybody's life better. So first of all, we have to remember that APS-1 involves all of the body. So although I might think that the gut is the most important part of the body, and it does have its own brain, and it's a huge neuroendocrine organ, and it's important for lots of things, I guess other people would argue with me depending on who you are. So we need to remember that we're a whole person, and what is happening in one part affects what's happening in another part. And particularly, I think in this syndrome, we have to think like that, because that's going to help us look at things differently. So if we look at the GI issues that have been reported in this syndrome, we can start at the top. And really, I should have started with the mouth, but and we don't have a dentist here today, but I'll start with the esophagus, which is one of my favorite organs. Anyway, and we know that the Candida infection in the esophagus is a significant problem in a reasonable number of people with APS-1. And I wonder if sometimes it's even a bit underdiagnosed in patients. Then you move down to the stomach. We talk about pernicious anemia. We talk about autoimmune gastric atrophy. And in both of the esophagus and the stomach, there's been some comments about whether or not there is any risk for developing malignancy. And then we go to the bowel, and everybody talks about malabsorption, but you have to remember that malabsorption is a symptom. And what you really want to know is what's the cause that's giving you malabsorption, and when you can work back from that, then maybe we'll be better at helping manage it. So people have talked about the effect of the hypoparathyroid hormone on the gut, just the fact of hypocalcemia and vitamin D regulation, infection, exocrine pancreatic insufficiency, this issue of autoimmune enteropathy, disaccharidase insufficiency. So most reviews will talk about lactose intolerance, but I think we need to group all of the enzymes that we use to break down sugars together, because they're all on the gut's lining. Whether or not lymphangiectasia, which will then cause you to lose some of your lymph, which is important again for absorption. This issue of whether celiac disease is or isn't really part of this syndrome. Celiac disease is the most common autoimmune enteropathy, but actually it's not really a big part of this syndrome. If 1% of people with APS have celiac disease, they're like the rest of the population everywhere in the world. And then the last is functional disease. And we know that as people are living longer and longer, that the effect of inflammation on the gut oftentimes makes the gut more sensitive in other ways, particularly how you feel. So the gut is also often considered a minor component, but again, maybe we need to think a little bit differently about that. If you look in series of patients with APS-1, they'll say about 25% will have some kind of GI symptom, and that's leaving hepatitis out of the picture. But rarely will they have severe involvement, and maybe it depends on how we're defining severe involvement, because what happens in the gut does seem to have an effect on what's happening elsewhere and your ability to manage things elsewhere. And now that people are creating more and more and more and more antibodies, whether or not doing general antibody screening will help point you in direction one way or another is not clear. Because we know in people that have autoimmune disorders, there are antibodies that suggest that there is some kind of autoimmune response to some part of the body, but those people tend to sometimes just make antibodies. So we need people to try to understand what does the presence of this antibody or that antibody actually mean in context of this disorder. So again, if we start at the top, and this is one of the hallmark diagnostic criteria for this syndrome, is this candidiasis. And we know that lots of people with this have oral candidiasis. But if you look further down in the esophagus, about 15 to 20% will actually have candidal esophagitis. And this can present with pain with swallowing, just chest pain, not necessarily attributed to eating or swallowing, difficulty with swallowing, things getting stuck, not going down well. And then in younger children, it's harder because we can't say, does it not go down well, but you'll see things like feeding refusal or feeding behavioral issues that seem to develop because of food choice. And if you have a younger child who has some failure to thrive, we know that in families, they're working so hard to try to get the nutrition into that child. And that child's, if you can ask any parent here, the first battle you have with your child is what they're going to eat and when they're going to eat it. And the second one is toilet training. So you're already set up for having some behavioral issue based on everybody's struggle to get nutrition in. And if you add that maybe things don't go down very well and we don't know that or don't understand that, that's just adding a whole nother component. So this is just a picture of what it looks like in the esophagus of somebody who has Candida esophagitis. So all this thick white stuff is just like what you see in the mouth, and it's causing a lot of inflammation and irritation in the esophagus. It also makes it not move very well. The second picture is just a picture of actually the little purple stringy things. I don't have a pointer here. That's the Candida that somebody's seen on the biopsy, and it's invasive. So sometimes people who are on steroids for their asthma, if you look down, they'll have a little bit of Candida, probably from their steroid use, but it's not invasive, where in this disorder, the Candida kind of goes into the wall itself and causes more inflammation. And this may be important in some of the long-term complications that we can see in people that have chronic Candida esophagitis. So there's really two long-term issues if we try to deal with the short-term one, which is that it really hurts when I eat and things don't go down very well, and I need to treat the Candida. In any situation where you keep having this inflammation, even if you have inflammation and healing, you can get scar formation or a stricture in the esophagus. So there are people with chronic candidal esophagitis in APS1 who need to have that stricture stretched, because otherwise it's a mechanical obstruction to the food going down. So if there's a change in somebody's swallowing pattern or they're having more trouble swallowing, then this needs to be looked into. The other is whether or not there's truly a risk, particularly as people live longer and longer, of developing malignancy. So in general, in the population, we know that there are risk factors for esophageal cancer, and this includes alcohol, smoking, and this may include secondhand smoke, which might be important in some people with APS1. I mean, definitely the attitude towards smoking has changed in the last 40 or 50 years, but then it will depend whether you are now 5 years old or whether you're 45 years old or 50 years old with this disorder, what your exposure to smoking may have been. There's some thought that maybe it's the combination of the risk of Candida and inflammation, but we could argue because we see in other disorders where we have chronic inflammation in the esophagus that may change the risk. So maybe it's the inflammation. And the kind of cancer reported, which again is extremely rare, has been squamous cell, which is not the most common. It's usually adenocarcinoma. And the only reason that I really bring it up is that when we look at people who have swallowing problems over their lifetime, who we think are at risk, even if it's slight, for developing cancer, they never have normal swallowing, but their abnormal swallowing is normal to them. So if you ask them, do you have trouble eating or swallowing? They'll say, no, I've been swallowing like this for the last 20, 30, 40 years. So you can't, whereas if I had the same symptoms that they had, I'd be off to the doctor right away because I would know that there's something wrong with me. So oftentimes they don't have the presenting symptoms that somebody needs to go and investigate them. So the issue is in adults, particularly with this syndrome and chronic esophagitis, whether somebody needs to actually look on any regular basis. And the only way you're going to get the answer to that question is the use of registries and looking at what happens and what risk factors happen to people. But I would encourage those of you who follow adults, if there's any change at all in their swallowing pattern, or if they have chronic, long-standing inflammation in the esophagus, they might actually need a surveillance. And I won't talk a lot about treatment, because except that we treat their candida just like you treat it everywhere else. Sometimes, and I met Julia because I have the swallowing clinic and she was having swallowing problems. So that's really how I got tagged into the team. So not only does she have inflammation in the esophagus, but she also doesn't really make saliva. And that's because of the Sjögren's syndrome, and that's part of her autoimmune. So the salivary glands are affected. But a lot of the advice that we give to people, or what you use to get stuff down, is your saliva. So again, it means you need to kind of think, how are you going to get somebody to swallow? How are you going to provide enough drinking, particularly if they have some issue with drinking water, to get the food down. So that's where having particularly OT or speech and people that have a lot of experience in that area, particularly when you're talking about younger children, is very helpful. And again, brings back the idea of the multidisciplinary approach. If you move down to the stomach, then we have this issue of type A atrophic gastritis, and probably the biggest complication from this that we see is related to B12 and B12 absorption. And this can start very subtle. And what I don't know, and again, following larger groups of patients will help. If we're looking at immune modulating therapy, are we going to change some of the risk for some of these complications, or are we at least going to push them back later in life because you're not going to lose that function for a while? And the parietal cells, or the cells in your stomach, that actually are important for absorption of B12 in your stomach. And there's actually antibodies against the protein that they produce for absorption. The other is that it also affects B12, may affect B12 absorption in the end of the intestine. So you might have more than one place where you're having issues with B12 absorption. And again, this question of when you start your immune modulating therapy, is that going to change either when these problems present or if they're going to present? And then there's diarrhea. So just like malabsorption, diarrhea is a symptom. It's not a disease. So you want to figure out why you're having your diarrhea and what you can do about it. And in this syndrome, there's many factors that contribute to it. Definitely the hypoparathyroidism, which is hallmark, can contribute to it. The idea of bacterial overgrowth, or the fancy term for that now is dysbiosis, and there are many reasons for this. They're related to the nutrients, related to malabsorption, related to all the antibiotics and antifungals that people are on, can change the flora that live in your gut that's so important for how well you are. Exocrine pancreatic insufficiency, which I'll talk about in a minute, hypocalcemia, this issue of autoimmune enteropathy. So again, that's a catch bag, because we have lots of different kinds of autoimmune enteropathy. And what we want to do now is understand what is your autoimmune enteropathy, what causes it, and then how do we treat it. And again, the most common autoimmune enteropathy is celiac disease, and we know that putting people on a gluten-free diet doesn't resolve this issue. So it's a different enteropathy. The issue of disaccharidase deficiency, does this help with your food choices and symptoms? This very, very small incidence of celiac disease, and at least from my review, it's not even as common in this disorder as it is in other autoimmune disorders. So it's not clear what the role of that is. And then I think we always have to remember, particularly as people get older, but even younger, can you develop an irritable bowel-like syndrome? And we talk about this now in every kind of inflammatory disorder in the GI tract. So we know people with Crohn's disease have Crohn's disease and have irritable bowel. People with celiac disease are left with irritable bowel even if they're very compliant with their diet. Some, not everybody. And it's sort of understanding what the role of this is. And then the last thing are drugs, because we're using a lot of drugs to treat this syndrome, and including immunotherapy, which can cause diarrhea or can cause the development of tolerance. So, for example, MMF is very common to cause diarrhea, and we need to drop the dose or stop it. And tacrolimus, we know we actually get this sort of allergic intolerance disease in the gut in other patients who are on it. So maybe our treatment is part of the problem in understanding that role. So the exocrine pancreas, so your pancreas really does two things. Part of it is the part that makes the insulin. So we talk a lot about developing diabetes, but the exocrine pancreas is the part that makes your digestive enzymes. And the exocrine pancreas needs the intestine to tell it what's going on in the intestine and what it needs to secrete to help you digest what's in your intestine. And we know that the intestine is a huge neuroendocrine organ, and there is evidence in APS-1 that there is problems with the neuroendocrine part of the intestine. So the real question is, how often is the intestine not telling the pancreas what it needs to do, and what role does that have in malabsorption? And there are definitely reports and comments about pancreatic exocrine insufficiency. We don't think this is autoimmune pancreatitis. There have been reports of antibodies against this part of the pancreas in APS-1, but people don't have autoimmune pancreatitis like we know it in other patients. So the question is the pancreas just not doing its job because it's not actually being told to do its job? And then we need to figure out what are we going to do with this? So if you don't develop you don't secrete the digestive enzymes, then you're going to malabsorb fat, you're going to malabsorb it's going to affect your absorption of calcium, it's going to affect vitamin D, it's going to affect vitamin K, which is also very important for your bones. So all these things fit together. The other thing is that I was sort of getting ready for this, I was reading some reviews, and one who mentioned this said that so then you give food that's very easy to be digested. So I would challenge this, and I would say that in this institution, 40 years ago, in the cystic fibrosis clinic, which is where the genetic disorder, that's the most common cause of pancreatic insufficiency, Gordon Forstner and Harry Levinson said, well, we're not treating people with CF correctly. We're everywhere in the world, we're giving them low calories and low fat. And they said that's wrong. And we gave them lots of calories and lots of fat. And the survival rate in CF in Toronto was way better than anywhere else in the world. So again, maybe we need to look a bit more of the effect of the intestinal problem on the pancreas, and do we need to think a bit more, or our dietitians think a bit more how we think in CF. Now, the intestine in APS-1 isn't the same as the intestine in CF, but sometimes we need to learn from other disorders and maybe change some of our thinking. And when we're looking at screening for malabsorption, if we take experience from elsewhere, actually screening for vitamin E is probably the most sensitive way to screen for fat-soluble or fat malabsorption, is looking at vitamin E levels. So it would be a good screening level, at least, to follow and make sure that that remains normal, and that we may actually start to see some vitamin E deficiency long before we start to have significant weight loss and other things. So the next thing, and I think there's going to be another section that's going to talk a bit more about the gut flora, but this whole idea of dysbiosis. So I tell people now you need to think of yourself as a large apartment complex. And in that complex, you have 100 bugs for every cell in your body, and you want to keep them happy. because when they're not happy, then you're not happy. And they're important for not only digestion, for your local immune system, for your systemic immune system, for metabolism, for drugs, for how your brain feels. Like, they really seem to run the show, and we don't really understand, or we're just beginning to understand what's their effect in health and what's their effect in disease. So on this little slide, this talks about everybody's microbiome, which is a little bit different because we're all individuals and we kind of have our fingerprint. That fingerprint basically is created by the time you're about 2, and then it gets modified over your lifetime, but you're kind of left with that early one. You can alter it by, in APS-1, multiple courses of antifungals and antibacterial definitely changes it. Diet restrictions, so I'm very interested in the effect of your diet on the microbiome, and we're looking at that specifically in formula-fed versus giving blenderized diet and really looking at the difference in it. Malnutrition, and then an altered environment due to malabsorption. So I think you'll start to see more interest in what's the effect of the microbiome and how can we alter to make it healthier. And again, there's treatment where we alter the microbiome. There is not one treatment that fixes everything. We sometimes use antibiotics because we hope that then we get rid of some of the bad bugs, or at least get them in less number and bring up the ones we like better in higher numbers. We look at antifungals because part of your flora is also fungus as well. So don't let anybody tell you that you shouldn't have any yeast in your GI tract. You just want it to be good yeast, not bad yeast. Probiotics, which are really to help promote a better mix. And then dietary diversity. And these are just some, in the lay press even, you can read lots of articles about your internal ecosystem. But there's a big interest of the effect of your internal ecosystem on the development of autoimmune disease. So one question is the difference between a brother and a sister who have this disorder related to what's the effect of the environment and the effect on their internal ecosystem over their lifetime, not only related to our choice of when we start immunotherapy, but lots of other choices. So then we get to this autoimmune enteropathy, again, which is a catch bag. So autoimmune enteropathy in general, outside of celiac disease, is rare. And there's a long list of different causes. And we are working very hard in individual groups to figure out the cause so that we better treat it. And we treat, John's autoimmune enteropathy very different than Sally's autoimmune enteropathy because they're not the same disorders. So if you look at small intestinal biopsies in APS-1, they don't look like celiac disease, okay? So they don't have villus atrophy. So it's not the same enteropathy. But if we look at staining and the antibody that seems to be most suggestive for having or developing the autoimmune enteropathy is the tryptophan hydroxylase antibody or autoantigen. And what this suggests is that there's absence of the enterochromaffin cells. So now we're going to the endocrine part of the small intestine, and if you lose these cells, then you lose all the things that they're supposed to do, the effect of these cells on everything else in the intestine, as well as the pancreas and the biliary tract. So what's important, and these aren't something that usually people look for if you go and have a biopsy done of your small bowel. The pathologist isn't going to necessarily stain for these cells because it's not something we're commonly looking for. So this information really comes from people who are looking specifically at what's the cause of this enteropathy based on this patient's symptoms. And so we know that over time that at least some people with APS-1 lose the staining for these cells, so we think they're gone. And so again, what does the enterochromaffin cell do? Well, it's important for growth in the intestine. It's important for motility, or how things move. It's important for blood flow. It's important for secretion of pancreatic enzymes. It activates vagal afferents, so that's the nerve that makes things move, and that's also the nerve that helps you feel. So for those of you that have kind of a sensitive gut, so we think that your vagus is a little sensitive too, and it holds most of the body's serotonin. So if you remember, when we're treating depression, we're using all these drugs to modify serotonin in your brain. Well, only 10% of the serotonin is in your brain, and 90% of the serotonin is in your GI tract. So what relation there is between this and what's going on in your brain, we don't know, but definitely affects the gut brain, and the gut has its own little brain. And this just is an example of the staining looking for these cells, and what you can see is the not the big red dots, but the little tiny little fine red dots. Those are the enterochromaffin cells in the GI tract. So if you stain for those in somebody with APS type 1, they may have them or they may not have them, or they may have less and less over time, so which may explain why symptoms change or some things get worse over time if you lose these cells. And this is just a slide. And again, it's hard to show somebody a picture when something isn't there because you don't know what you're missing. So really in the two, the right and the left, compared to each other, where there is the little black spots, that's the cells being there, and then somebody stained in a patient with APS type 1, and they're missing. So we assume then all the function that those cells are supposed to do is also missing. And whether or not it's part of this autoimmune disorder, whether or not you lose some other function over time, at least for the moment, this is what's clear. So if we say that 10% of patients with APS type 1 present with GI symptoms, it's very variable what their symptoms are. Does affect children more than adults, which doesn't quite fit with this loss of these cells over time, but whether there's some developmental or some growth issue, I think we don't know, and those are the things, again, that will come from registries and diagnosing people earlier and looking at things from patients that are earlier. Diarrhea is just a sign of malabsorption, so I would remind you to think of the pancreas as well, because it's left off of a lot of lists. And the gut has variable response to immunotherapy, or whether earlier immunotherapy is going to change the long-term effect on the gut and the gut function. Again, you're going to know that from having a registry where you follow a larger number of patients and you can answer those questions. Again, celiac disease is very uncommon, despite the fact that it is a very common autoimmune enteropathy. Infections of the gut, again, this issue of candidiasis, Clostridium difficile from all the antibiotics. This is the infection you get when you're on antibiotics a lot, because the bad bacteria get into a high number in the gut, and the good bacteria get pushed down, and you want to get them in better disorder. Or other things like beaver fever or giardiasis, again, which relates to local immunotherapy, local immunocompetence. And for example, if you live in Ontario and you have a cottage, I hate to tell you, but most of the lakes in Ontario actually have giardiasis. And lots of healthy people get giardiasis and don't get sick. But at least we need to think about it in this group of people, particularly if you've been somewhere where you could have gotten it, and probably places that you don't necessarily think about. And this is separate from this issue of dysbiosis. So I think, last issues is, can you develop functional GI disease over time? And this is the idea that any kind of inflammation in the GI tract can set you up for becoming sensitive. And if we think about that serotonin and the feeling and the vagus and the feeling, that already there may be some things going on with people with APS that might make them at more risk for developing functional or IBS, and we need to think about how we treat other people with IBS and remember that in this disorder. And that's kind of getting back to the idea of the whole person. And then lastly, coming from the pediatric point of view and a swallowing clinic, we just really need to remember that some things that happen very early on, related either to symptoms or how people approach the problem, can really set up for dysfunctional feeding and eating behavior on the part of the patients as well as the parents. And when you speak to parents who had a child who really had failure to thrive, for the rest of that child's life, all they can think about is how skinny and unwell that child was, and they have a hard time, even when that child's standing in front of them eating a broad range of food, that they're not worried that that child's going to quit eating again. So we need to remember that as we're dealing with families. So again, GI involvement is minor. Let's put this in quotes because I think the gut's extremely important, and symptoms may actually be a major issue, or the gut may be contributing to problems elsewhere. Growth can be affected. It's probably a combination of the preceding issues. You need to think broadly, and the role or what the effect of immunotherapy is going to have on the GI tract is not really, I think, sorted out yet. Thank you.